Well, today's event wouldn't have been possible, obviously without our sponsors, but also without our Parkinson Award Association for 20 board members and all the board members in the room. If you could please stand so we can just acknowledge their volunteer and dedicated upward. I think number still out of the river creek. Oh, thank you.
Yeah. Photo.
I'll go ahead and list them. Yeah. John Duck is our president. Treasurer Jeff Brotziller, right here in the front. Our unofficial VP of Silent Auctions, back there in the back, Joanne Wojcieszek. Member at large, that would be me. Dr. Ed Daly, who was unable to attend today. Kathy Kruger, she's back there in the back. Tom Little is out at the registration table. Wendy Epstein back here, and was great to bring her students to health. And I think there was somebody else. And then, of course, our Executive Secretary, Sherry Vermillion. Here she is before you go out the door. Thank you, Sherry. All right, we'll keep it moving. So Pacey is pleased to announce our speaker today. Many of you probably already know her, maybe not, or here to beat her. Dr. Joanne is Dr. Joanne Wojcieszek. She is the 2019 Connie Carney Award recipient. That's an award Pacey gives out every year to someone who has contributed to the Parkinson's community. Dr. Joanne is a clinical associate professor in neurology at the IU School of Medicine and director of the Movement Disorder Clinic at the Indiana University School of Medicine, and a senior member of the neurology staff at the Huntington's Disorder Clinic. She's been an avid supporter and provider of services to the Parkinson's community and promoter of Pacey for more than 20 years. We were trying to figure out how many years, but more than 20, the good number. Yeah. On numerous occasions, she has been the keynote speaker at the Pacey Annual Symposium and has been an invaluable resource of assisting us in recruiting nationally recognized speakers for educational events, and has advocated the importance of Parkinson's support groups throughout the state of Indiana. She had the honor of being nominated by the late Senator Richard Lugar to be a local legend indeed. Please welcome Dr. Joanne.
Thank you, everybody, and I hope you can hear me. I want to just comment that maybe 20 years ago, we had a lot of people in the audience who had a lot of dyskinesias, and people were wiggling around and having a lot of involuntary movements, and now everybody looks really good. And they've come a long way with our treatments because people don't have as much dyskinesia as we used to have. And I think that's thanks to deep brain stimulation and also the discovery of amantadine to help dyskinesias. So everybody looks really good. And so the audience looks great. Compared to 25 years ago, things are different, okay? I'm going to have Jeff help me with these slides. And I think I got to go to church today because it's a miracle that we got this set up to work, to get the slides going. It's time to go to church. Okay. Because it's a miracle that wire fit into my computer. It's all meant to be. Okay. So I'm going to just show you some slides just because I think images are important. These are some really important people who have been good role models for how to handle having a complex, progressive, degenerative disease like Parkinson's disease. And I think Michael J. Fox has done an amazing job at not only just being a good role model and helping everybody learn how to live with Parkinson's, but he also has really started the Michael J. Fox Foundation, and they have done more for research than you ever could imagine. We would have really not been where we are without him. And then we have Scott Newman, our local celebrity and hero, who started Rocksteady Boxing, and I'm going to say a lot about that today. And you'll see some pictures of the Rocksteady boxers intermixed with some of the slides. Pope John Paul showed us that you can have Parkinson's and continue to work and do your job until the very end of life. And then Muhammad Ali, also a wonderful role model, wonderful individual, And Linda Ronstadt has been in the news lately that she was a wonderful singer and now she can't sing. And so Parkinson's took that very important thing away from her. What's really scary is I showed some of our students a picture of Linda Ronstadt and they didn't know who she was. I said, oh no, but all right, become a singer. So I don't want to say too much about the cause of Parkinson's disease because I don't think we know what causes Parkinson's disease. Sporadic Parkinson's, 85% of people who have Parkinson's, they have it just, we don't know why we don't know why we got it, okay? 15% is hereditary and the other 85%, this is the problem. We don't know how the whole darn thing started, just like with ALS, just like with Alzheimer's. And I got some good news and I got some bad news for you today about research. So we're going to talk about that. So we think it's probably a lot of different ways to get there. You can get there, I think, through a viral illness like recurrent flu. Okay, viruses, we know, can trigger neurodegenerative diseases, but I think there's more information now about all the toxins. Rotenone, paraquat, MPTP, and there's a lot of it, pesticides and insecticides all around us. And I think that's why Parkinson's is increasing in how many people are getting it, is because we have so much junk in our world that we're being exposed to, and it's causing changes in our body. They have these things, I just want to say, oxidative stress, mitochondrial dysfunctioning, genetic factors, but I just don't think we know enough to say much more about it. We're going to continue on to the next slide. I wanted to historically talk about the milestones of things that I think have made a big difference in Parkinson's in history. First of all, it wasn't James Parkinson, I want to correct this, who described Parkinson's disease. It was the Indian Pakistani culture 5,000 years ago who discovered the disease called Campavada. So they're the ones who should really get the credit. And then they've been using mucuna pruriens, which is a natural substance that grows in a plant form to treat their Parkinson's, because mucuna pruriens really does have levodopa in it. And a lot of my patients increasingly are using the natural form of levodopa as opposed to the CVS Walgreens brand of levodopa. So I want to go back to 5,000 years ago, when we should give credit where credit is due to these cultures that didn't happen to speak English and weren't white-skinned, and they didn't get the credit for it. Yeah. So in 1960, there was an Austrian neuropathologist, Dr. Oleg Hornikevich, and he looked at these brains of Parkinson's patients, and he examined them after the people died. And he said, there's something I've noticed about these brains that didn't have enough dopamine in them. And the world said, no, you crazy. It has nothing to do with that. Go back to the lab and try again. But he didn't give up. He went on to continue to believe that he was correct. And in 1967, he infused the first Parkinson patient with IV levodopa. And wish I could show you the video, but it was too complicated to bring today. Someday I hope to share that with you. I think we've shared it with some groups in the past at these meetings. But in 1967, he infused a levodopa, and it was a miracle drug. Then in 1970, somebody else got the credit who won the Nobel Prize, I won't mention his name, and got the Nobel Prize for bringing levodopa to the entire world. In 1990s, we started to get a handle on the psychosis for Parkinson's, because people do get hallucinations and they start having lots of problems from this illness of Parkinson's psychosis. And in the 1990s, we began to finally have a medication called clozapine to help with managing that without making the Parkinson's worse. And now we have pimavanserin Nuplazid, which you've seen on television as well. In 1997, the first gene for Parkinson's disease was found in the Contursi kindred in Italy in a family, and it was the alpha-synuclein gene that caused Parkinson's in this family, and this was a big breakthrough. Nobody believed that it was genetic in any way before here. And the alpha-synuclein was a protein that nobody had ever heard about. Nobody had heard about this gene that makes the alpha-synuclein protein, and it turns out that's the stuff that's in Lewy bodies. Gee, there's more to this story. So alpha-synuclein was a huge discovery. In 2002, DBS was approved for Parkinson's disease. This was a game changer for so many people. We didn't have anything like that to help with advanced Parkinson's. In 2013, some neuropathologists in Chicago looked at the brains of patients who had died after they had had embryonic stem cell transplantation. That means that they had had aborted fetal tissue, the dopamine neurons from there, transplanted into their brain. And then to see, that was a study that was done a number of times. And then when they died, they looked at the brains and they found out that the new neurons from the transplanted organs were making dopamine. They turned into dopamine neurons, but they also had Lewy bodies. So we found out that the old nerve cells with the Lewy bodies were contaminating the new transplanted neurons. And so Parkinson's is an infectious disease in the brain because the bad protein is pooped out of one cell and picked up by its good neighbor, the good neighbor policy. We're just too kind around here, okay? And so one cell to the other, this is called the prion hypothesis, where Parkinson spreads from cell to cell. And this finally explained to us, how can you have a slowly progressive disease? When you have a stroke, you get your symptoms right away, and then you get better over time. But why would you have something that gets worse over 35 years? What's the mechanism of how it goes from one part of the brain to the other? And this was the final explanation. And to me, this was huge discovery in terms of understanding the progressive nature of this disease. Then I think we know we want to have continuous treatment, whether it's DBS or continuous dopamine infusion. So then we had the duopa pump discovered since 2015, and then now we have the subcutaneous levodopa that it's on its way as well. And here I just want to show you that what really we're talking about is the alpha-synuclein protein. It really gets clumped up, and then when it's clumped up, it gets into the Lewy body, and it constitutes most of the Lewy body. Next slide, please. I gotta speed up because we could talk for hours here, but we only have 45 minutes. Okay. Most of the time, I want to talk about the diagnosis of Parkinson's. Just a couple of few things. Most of the time, it's the history and the physical are sufficient. If you tell me the story, I see what you look like, and in 5 minutes, we know what we're dealing with. Okay, because sometimes things are very straightforward. There are some people who it's not clear what they have. Maybe they've had essential tremor all over their life, and now they've developed a resting tremor on one hand. So then we have to do what's called a DAT scan. And I want to let you know that we don't usually order this on most people to make a diagnosis. This is a DAT scan done in the nuclear medicine department of a lot of big radiology departments. And you infuse some radioactive iodine, and then we look at the dopamine system. And in a Parkinson's patient, you have 2 periods, whereas a non-Parkinson's healthy basal ganglia, you have 2 commas. And so here's 2 commas versus 2 periods. And so this is a test for Parkinson's that we can do some of the time. And insurance is increasingly covering this. This is a very safe test. It's like a couple hours out of your day. Anyway, the new thing, I think, is the skin biopsy, okay? There's an understanding that Parkinson's begins in the gut, and it travels up your brainstem, and you have a lot of prodromal symptoms of REM behavior disorder, constipation, anxiety, depression, before you get your motor symptoms, because it's traveling up the brainstem. And we're catching people who have prodromal Parkinson's disease, and we're trying to figure out, how do we make this diagnosis earlier? Parkinson's affects your whole body, and these clumped up proteins of alpha-synuclein, they are in all the nerves of your body, everywhere. And so now we have a skin biopsy that we can do looking for alpha-synuclein clumps, and then you get this picture back that has the red areas which show that there's immunofluorescent staining showing that there's phosphorylated alpha-synuclein clump in your nerves, in your skin. And we're going to talk about that in another slide. Next slide, please. I want to just say about the DAT scan, this is a high sensitivity, but it's not 100% sensitive. So maybe like 95% sensitive. That is, what is the chance that if you have a disease, the test will be positive? And it's not 100%. So there are some people who just have a little bit of tremor, and their DAT scan can be normal. I just want to let you know it's not 100%. It's also not very specific. It cannot distinguish between Parkinson's disease and the other Parkinsonisms like multiple system atrophy or progressive supranuclear palsy. And so there are some people who have a normal scan And I got to tell them, let's check it in a couple years and see what's going on. Next slide, please. So the skin biopsy to look for abnormal form of the protein called alpha-synuclein in the nerves of the skin. This is the new test. We're looking for phosphorylated alpha-synuclein. And there's a biopsy in 3 locations: the upper back, the lower thigh, and the lower leg. And you use local anesthesia, and you don't need any stitches. And it's about 95 to 98% accurate that you have alpha-synuclein in your nerves. And this is seen in Parkinson's, Lewy body dementia, multiple system atrophy, and REM behavior disorder, which is a precursor to Parkinson's disease. Next slide. So as I mentioned, we have a hypothesis called the Brock hypothesis. Dr. Brock, a neuropathologist who thought that maybe starts in the abdomen and it works up the brainstem, and these are the stages of Parkinson's disease. In the beginning, you just have it in your nose. You have it in the nerves of your nose, which is why people lose their sense of smell at the very beginning of Parkinson's before they have any motor symptoms. And then it spreads not only to the brainstem where it causes the motor symptoms, but it also spreads to the thinking parts of the brain where it can cause the cognitive decline and the dementia. Next slide, please. So this is the Brock classification, and again, we think this is a prion disease. Does it travel via the vagus nerve in the stomach to the brain? The vagus nerve is the one that transmits information around your stomach and intestines, and the nerve transmits information back into the brain, but it also may be transmitting the prion type protein of alpha-synuclein. So these are the stages of Parkinson's disease, and the stage 1 is in your nose and maybe in your gut, and then by the time you get it in your brainstem, it's already stage 2, and so when you're diagnosed, you probably already have stage 3 disease, and this is the same thing that happens in Alzheimer's disease. We are really late in the game of making this diagnosis because by the time we make it, it's stage 3, okay? Imagine if you had 5 stages of cancer and somebody tells you have stage 3 already. That's not very good news, okay? So we gotta get better about this, and the skin biopsy might be the way to go in terms of finding people with early disease so we can actually start treating them before they get their tremor and other motor symptoms. Next slide, please. Just want to say just one thing about the genetics of Parkinson's disease. About 15% is hereditary. It's not even a blood test. It's a swab in your mouth, and you send a Q-tip back to us, and we can do a Parkinson's panel and look for all the common Parkinson's genes if we want to do that. And I would just say that there are 3 genes we're going to talk about: LRRK2, GBA, and Parkin. Parkin is causing a lot of young onset Parkinson's, but for the adult older onset, we have these 2 genes. And these are the 2 that are sort of screened out in 23andMe, but 23andMe only looks for 1 mutation of GBA and 1 mutation of LRRK2. It does not give you the whole information. So I don't think you should do this. I think you should just get the PD panel through us. So I want to say a couple things. If you are in the United States of America, which we are in, the best country in the world, okay, and you have Parkinson's disease and you're older, and you don't have a family history, nobody in your family had Parkinson's, you only have a 1% chance of having this LRRK2 mutation. If you have a sibling or a parent, then you have a 5% chance of having this gene. If you have Parkinson's disease, no matter how old you are, you've got a 5% chance of having this GBA mutation, and we're going to talk about this in depth in just a second. This is the most common genetic risk factor for Parkinson's disease. These genetic forms of Parkinson's may lead to very specific treatments, as we'll talk about in the next slide. I think you should know what's causing your Parkinson's if you can, just for intellectual understanding of your disease. Next slide, please. Gaucher disease. Okay, Gaucher disease is a genetic disorder. It's caused by this GBA mutation in the DNA. And one of the interesting things is what happens in Gaucher disease, that the long name for this enzyme is glucose cerebrosidase enzyme. We won't talk about it. We'll talk about GBA. So what happens is in your cells, you have ways to get rid of garbage. You have ways to dispose of garbage. And one of the ways that you dispose of garbage is in a lysosome. So in a lysosome in your cells, you have these enzymes which chew up garbage. And if your lysosomes are plugged up and they're not working, you're going to get garbage buildup. And this is what happens in Gaucher disease, and it's also what happens, we think, in Parkinson's disease, that we're not chewing up our garbage proteins like extra alpha-synuclein. So if you get testing, if you get DNA testing for Parkinson's disease, you may be told that you have 1 dose of a GBA mutation, and that just tells you that that had put you under increased risk for having Parkinson's disease because your lysosomes are not working very well. And then if you have 2 doses, and I do have patients who have Gaucher disease, they have 2 doses of these mutations, and they have Parkinson. Okay, next slide, please. So GBA mutations are found in Gaucher disease. They're very common in Ashkenazi Jewish people. And that's why when you come to my clinic, I ask you, does anybody in your family have Parkinson's? Are you Ashkenazi Jewish? Okay, those are probably the first 2 questions I ask. Then we are told, just to remind you, that GBA mutations are the most prevalent genetic risk factor. They increase your lifetime risk by 20 times of getting Parkinson's disease. So this is a big deal, okay, to have one of these. Overall, GBA mutations are present in 5% of all Parkinson's patients. Next slide, please. So this is for Rick Spear. This one is for Rick because Rick asked me to comment on Ambroxol. And I'm going to comment on Ambroxol. So Michael Oken, who is really the representative for the National Parkinson's Foundation, and he really addresses a lot of these controversial questions. And I appreciate, reading what he says about these things online. So what is Ambroxol? Ambroxol is a mucus agent. I could use some of that myself because I've been having a flu lately, and I might cough during this talk. So I need some Ambroxol today. Ambroxol reduces sputum and is frequently mixed into cough syrups. Okay, it's administered for common colds and congestion, and it degrades these proteins called mucopolysaccharides. The idea of Ambroxol is to make sputum thinner and less viscous. It has been shown to also have an anesthetic effect as a common treatment for sore throat. The rest of the world has Ambroxol. We do not have it here in this country. The drug became widely available in 1978. It's over the counter in many countries. And so if you Google it, you'll see all these different preparations. It's an anti-mucus medication. Next slide, please. Ironically, it was Gaucher's disease that has been in the relationship with Parkinson's that made us interested in Ambroxol. So we know that in Gaucher's disease, you get a buildup of junk, and it's caused by a deficiency of an enzyme. So researchers were searching for Gaucher treatment, and they looked at all these possible drugs, and they found Ambroxol. Ambroxol was found to help their lysosomes help function better. And so they found out that Ambroxol can possibly help Gaucher disease because it boosts up the function of the lysosome. And so it's being tested now in Gaucher disease formally. But then they say, hey, we got all these Parkinson's patients who have Gaucher mutations. Maybe we could use Ambroxol for our Parkinson's patients. Next slide, please. So Anthony Shapira and his company, they did a study called the AIM-PD trial. And they asked, can Ambroxol efficiently travel to the brain? Can it get into the brain? And the answer was yes. And what if you give people with Parkinson's Ambroxol, whether or not they have GBA mutations or not? And it turns out that it can get into the brain, and it was safe. And they're looking into it. And there's another study called the ASPRO-PD study, and the ASPRO-PD study is going to be checking on this drug in Parkinson's disease, and they're going to be looking for people in the, they're going to be looking for people in the UK with Parkinson's to be part of this study, so stay tuned. Now you might say, should I be taking it? Well, I guess if you want to get it online and try it, it's a cough medication. I'm saying you could try it. I mean, I'm just not recommending it. It's not proven, but it is safe and it's approved in other countries. So, Rick, that's my answer is that, if you wanted to try it, it's not a dangerous thing to try. Okay, next slide, please. So, I want us to be aware that there's a lot of things that have been kind of preliminarily presented to us that turned out not to work out. Coenzyme Q10, creatine, nilotinib. Remember nilotinib was that cancer chemotherapy agent that everybody wanted to get on? They went to hemonc doctors after preliminary evidence showed that it might help Parkinson's neurons. Well, then it turned out not to be effective and it has a lot of side effects. So you just can't get on the bandwagon of anything unless you really know the risks, of that drug, and it's not proven. And that's the message that I don't recommend any of these things because they're not proven. But if you wanted to do it and it's not too dangerous, that is your personal decision. So the Lewy body is a big player here. We know that in the neurons in your brain that are remaining, we have Lewy body inclusions. So here is a healthy patient who has pigmented dopamine neurons in their midbrain. This is a Parkinson's patient in whom the pigmented dopaminergic neurons have died. This is an autopsy, real brain. And then if you look under the microscope, these dopaminergic neurons in a healthy person versus in a Parkinson's patient, they have lost a lot of the dopamine-producing neurons, and there's a Lewy body in the ones that are remaining. Next slide, please. So there's a clumped up alpha-synuclein. Okay, let's try to attack that. We've talked about this in the past as well. We know that this is being found in all the tissues in the nerves of your body. Let's either give a vaccine or a monoclonal antibody to help your immune system go after the alpha-synuclein. Maybe if we get your immune system either vaccinated against the protein or give you a monoclonal antibody, maybe that will destroy and chew up all the extra clumped up protein around your nerves. And maybe that would work. And that is what people have been working on. Next slide, please. I got some bad news, okay? Very bad news, and I'm very disappointed. There have been 2 major clinical trials of either the monoclonal antibody or the vaccine. They've been negative. Cinpanemab and then prasinezumab, whatever. There's the Pasadena study and the Spark study. Some of these were monthly IV injections. So this immune treatment is not working. It has not worked so far. And the same thing is happening with the Alzheimer's. Okay, the Alzheimer's people also have been trying to get rid of the clumped up, alpha, A beta or the amyloid protein, and that's not really helping. Maybe we're just too late. Maybe we are just too late for this type of treatment. So stay tuned, but I do have bad news that these studies have been negative. Next slide. Let's go back and just talk about how we treat Parkinson's day in and day out. So in the blood versus in the brain. So we take levodopa, we take dopamine. Dopamine cannot get into the brain. It has to be given in a precursor called levodopa. So you get levodopa, it gets into the brain converts it to dopamine, it splashes the dopamine receptor. That is how levodopa works. It is the best treatment for Parkinson's that we have. You can also have a dopamine agonist, which will mimic the effects of the dopamine at the dopamine receptor. We got pramipexole, ropinirole, rotigotine. We have drugs which block the breakdown of dopamine called COMT inhibitors and MAO inhibitors. And these block the breakdown of the dopamine. We'll talk more about this. Safinamide is a new MAO inhibitor in addition to selegiline and rasagiline. And then our COMT inhibitor that we use is entacapone, and now we have opicapone, which is a once a day. We also have anticholinergic drugs like trihexyphenidyl artane and benztropine cogentin. And these work to help in a miraculous way to help Parkinson's symptoms. There's a new medication called Neuriance. It's known as istradefylline. This is working on a different receptor called the adenosine receptor. It's an adenosine blocker, and it's been in Japan for 9 years. It's been in the U.S. since 2019. So it's an add-on to levodopa. Next slide, please. I want to talk about levodopa therapy. When patients start on levodopa therapy, they have a continuous 24 hours a day smooth symptom relief, even though the half-life of the medication is only 90 minutes. So when you first get on Sinemet, you can take, all 4 tablets in the morning, and you're going to be fine because you're able to store it. Your brain is able to store it in the remaining neurons. and release it in a continuous physiological manner like it should. So people are in a honeymoon period when they first start taking this medication where their symptoms are well controlled day and night. This is because the levodopa that's taken by mouth is stored in remaining healthy dopamine neurons and continuously released. The timing doesn't matter early on in Parkinson's. Next slide. After 3 to 5 years, about half of patients develop less ability to store the levodopa, causing the wearing off, and the receptors start to get sick, and they don't respond to the medicine normally, and that's when you get the dyskinesia, okay? So the wearing off, the patient says, oh, my medicine used to last 5 hours, now it's lasting 4 hours, and over time, it may last down to 2 hours because you can't store it anymore. This is due to the fact that you have fewer neurons with storage capacity, and you have a drug which has a very short half-life of 90 minutes. The dyskinesias are the wiggly choreiform movements that usually appear about 1 hour after each dose of levodopa, usually at a peak dose effect. It's caused by changes in the dopamine receptors where they don't react to the medicine like they should anymore. I want to just say a couple things about this on-off, which is a term that's misused by everybody in the world. In very advanced Parkinson's disease, some patients may report a very uncommon but very severe phenomenon called on-off. The levodopa was working well. I had just taken my doses, and in the middle of the dose, all of a sudden my Parkinson's symptoms reemerged. No problem. My Parkinson's symptoms reemerged, and then suddenly they got better. So actually, you're in the middle of a dose cycle, and you completely turn off, and then you turn back on again without taking any more medication, and you go on again, off again like a yo-yo. I froze up, couldn't move, and I couldn't walk. This is a dopamine receptor problem and very difficult to treat. This is a receptor problem. That means that your brain doesn't want to respond to the medication anymore, which is really, really bad, okay? That means you can't just fix that quickly with any amount of medication. Okay, next slide. So the motor fluctuations of Parkinson's disease, we have wearing off, which is a very common thing that at the end of the dose, your symptoms come back, but you have this on-off effect, which is very rare and only in advanced disease. Next slide, please. So what happens is that the duration of levodopa benefit changes over time. I don't know of any other disease where this happens with a medication. Whereas initially it lasted 6 hours, then 4 hours, then 2 hours, then a half an hour. And so you get really into this very troublesome situation where your medicine is not working, and then it's time for DBS. Next slide, please. And then people have these motor fluctuations where they go from off to on, and then they get dyskinesia when they're on. And the green is like a good time, and that gets less and less of your day as time goes on. Okay, next slide, please. Want to just say that coming soon is the subcutaneous levodopa infusion. You can see that there's a tiny needle that's put into your stomach and or thigh, and then you have an infusion pump that delivers levodopa continuously. That's coming soon, but let's go to the next slide. The continuous 24-hour sub-Q levodopa is coming soon, and I asked Dr. Zauber, who did this study with her patients, and it's for patients who have very poor control of motor symptoms on oral levodopa. They have a lot of off time, and they're close or waiting for their DBS therapy. They get a lot of skin infections. There's extra skin bumps, and you actually get more medicine infused, and you get hallucinations, and you get side effects. The pump is heavy, and you need to have help of a caregiver because you got to fill the gadget up every morning, and we don't know how insurance is going to cover it. I would hold off on this for now, unless you really are having problems. Next slide. We also have new formulations for symptomatic treatment. We have the istradefylline, the Nuriance, 20 milligrams for a couple of weeks, then 40 milligrams, and it's an add-on to levodopa. We have the inhaled Ingrija levodopa, inhale. We have opicapone, which is a once-a-day. The new entacapone is the opicapone. The apomorphine sublingual has been taken off the market, but we do have Apokyn, which is a rescue therapy for people to shoot themselves up to turn back on in 5 minutes, which really does help them quite a bit. Then we have our long-term, once-a-day, long-acting amantadine preparations of Gocovri and Osmolex ER. We have Xadago, which is like a new formulation of selegiline and rasagiline. And then sometimes there's other things that we can use for motor symptoms. Next slide, please. And we also have Rytari, and then we have our Duopa pump, which is a liquid form of levodopa that's on 16 hours infusing into your small intestine. Next slide. What about all the other problems? We know that there's a lot of problems with Parkinson's disease that are not just about tremor, rigidity, and bradykinesia. And you get all this other stuff. So it's a lot of different problems that can happen. Next slide, please. It's a total body disorder. We also found out recently that 40% of patients have peripheral neuropathy with Parkinson's disease, compared to 9% of the general population. So peripheral neuropathy, it's usually a small fiber neuropathy with burning in your feet. Starts in your feet, and then when it goes up your leg, then it gets into your hands later. It actually, I think, is something that's quite significant. They looked at 100 patients with Parkinson's disease, and they did those skin biopsies, and they found out that they didn't have the small nerve endings like they should. The association of peripheral neuropathy with Parkinson's has different explanations. Is it really related to the dopamine? Well, it's interesting because people who get the Duopa pump, they have more of this neuropathy. Is it from the levodopa in some way toxic to the nerves? Is it related just to the alpha-synuclein in some way? Is that clogging up the nerve? Or is it, some other diseases that contribute? Next slide, please. So that's an interesting little bit of bad news that 40% of people, maybe 50% have a small fiber neuropathy that could be contributing to their gait problems and balance. I also want to talk about some things, again, that are out there but not approved, off-label use of some medication. There's been a big interest in the past 5 to 10 years about diabetes drugs and are they neuroprotective for Parkinson's disease. Pioglitazone has been tested. It's a drug for diabetes, and it's not helpful for Parkinson's disease. But there's this one called Byetta and exenatide. And these are drugs which actually help diabetes, and they help the sugar get into your cells, and so your cells function better. They work with the pancreas to, they do all kinds of things for diabetes, and I don't know much about diabetes, but this is a diabetes drug, and there's increasing evidence from several studies that this could be very helpful to treat the motor symptoms of Parkinson's disease. Not just the motor, but the non-motor and also cognitive. And so there are some big studies coming up, hopefully, to clarify this. Now, it can cause reduced appetite, nausea, and abdominal pain. Now, a lot of people are taking, who have big bodies, they're taking this diabetes drug. What is it? What is the one that everybody's injecting now to get skinny? What is it? Ozempic? Yeah. Okay, so so a lot of people, and even Weight Watchers might be starting to do this. We're starting to use these diabetes drugs for other things, okay? So Ozempic is is it once a week or something like that? Well, it turns out that there's so many Hollywood movie stars that are using up all the Ozempic that people with diabetes don't have enough of it. So people are using Ozempic for weight loss. And I've talked to somebody I know was taking it, and she got so sick. She had abdominal pain, anorexia, didn't want to eat anything, felt miserable, felt so yucky, so she had to stop it. So these are drugs which have, a lot of potential side effects. You may not tolerate them. I've had some people who have injected themselves with Byetta because they got it from their doctor because they thought it was going to help their Parkinson's. So this is being done. People are doing this, okay, on their own with their primary care doctor. And I just want to let you know about it. I'm not recommending it. I'm just giving you information that this is going on. Next slide, please. This is what has really changed the way we handle Parkinson's disease. Deep brain stimulation. It's a surgical procedure with an implanted device. We've been doing it for over 20 years. And the risk of serious side effects is really minimal. It's only 1%, okay? And then here, next slide, please. There are 3 companies that make the devices, and they're all very good devices. I just wanted to comment that Increasingly, we're using rechargeable batteries, which last a long time. Medtronic was the first company. They approved their DBS system for the first time in 1997 for essential tremor. And it's been used and approved since 2002 for Parkinson's disease. They do have a replaceable battery. And now we have these things called segmented leads where you can stimulate a third, or a third. You can decide which part of the third, 1/3, 2/3 of the space that you want to use. So these are called segmented leads, and everybody's got those. I don't even want to compare all of them. I just want to say Boston Scientific has been approved since 2017. And one of the good things about them is that you can use a lower pulse width, which really helps us sometimes with side effects. And their remote is very simple to use. It's a simple remote, not like a telephone. The Medtronic folks use a telephone, iPhone type deal, and so do the Abbott folks use an iPhone type deal. The big thing about Abbott is that you can do remote programming. So if somebody lives in Evansville, I'm going to recommend that they might get an Abbott so that our nurses can program them over the computer without having to actually have them come in and change their setting. Next slide, please. Okay. So who should consider a DBS? Well, if your medicines are not having enough effect on you, that your quality of life is not good, then you should consider about a DBS. The happiest people in the planet are the ones who had severe tremor, and the DBS got rid of their tremor. The second happiest group are folks that had horrible side effects from their medication. They had hallucinations, they had impulse control disorder, they had a lot of things they couldn't handle, carbidopa, levodopa. They're very happy with DBS. And then people who have a lot of off time or lots of dyskinesia. We are starting to consider DBS before you get your levodopa-induced complications. Why would you wait to have the dyskinesias and have your receptors messed up from the dopamine when you can get this treatment earlier? Because we know that levodopa is doing a number on your brain. Okay, next slide, please. Who should not have a DBS? Well, if you're very depressed and anxious and your emotions are not well controlled, or if you have dementia, if you're unrealistic, if you have a lot of medical problems, if you didn't really respond very well to medications, maybe you don't have Parkinson's disease, you don't have good family support, and if you work with electricity a lot, you can't, like if you have an electric fence and you have a lot of horses and you have an electric fence that you're always fixing, you can't be exposed to electrical currents. Next slide, please. So our IUPD DBS team, we have Lindsay Shanklin. Lindsay, do you want to stand up and say hi? This is our social worker, Lindsay Shanklin. And many of you, let's give her a round of applause. And she is helping so much every day with our patients. Lindsay, this is Lindsay. And so she's our social worker for the DBS program and for the Parkinson's clinic. We have our DBS nurses, Carla and Laura. We have two surgeons, Dr. Witt and Dr. Gupta. We have a chaplain, Bruce Pfeffer. And so these are some of the people involved with our DBS team. Next slide, please. I want to just say one thing about the focused ultrasound. So DBS is a brain surgery. The focused ultrasound, you still have to come in. Your head has to be put into a frame. And then we beam some radio waves. Our surgeons beam some waves through your skull into a part of your brain where a couple of cells are destroyed. You can only have it done on one side. And there's some recent publication talking about the focused ultrasound using sound waves to make a lesion on one side of the globus pallidus for patients with Parkinson's disease. It's not a risk-free procedure. You can have slurred speech, gait trouble, loss of taste, vision trouble, facial weakness, all those things. Like a TV commercial at the end, they tell you all the problems, okay? I think if you're like 100 years old and you can't get a DBS, and you got really bad tremor on one side or something, you could think about this procedure. It's not a brain surgery, but it's not a simple thing to do. It's a huge procedure. Next slide. The vibrating glove for Parkinson's, hope, hype, or both. Michael Olkin again wrote about this. Peter Tass is a well-known and accomplished neuroscientist at Stanford who has developed gloves for Parkinson's that are designed to be worn a few hours a day. The gloves provide some vibration to the fingertips and hands, and he's trying to reset the brain oscillators just a little bit like DBS does. This laboratory previously has been studying DBS and trying to reset the brain networks, and that they have not produced a large study, so I don't know if it works. It's not been studied in a large scale. Next slide, please. But we do want to just remind you that Jean Charcot, who was the father of neurology in Paris hundreds of years ago, brought vibration therapy to neurology and specifically to Parkinson's disease. He developed a vibrating chair for Parkinson's disease. And why did he do this? Because he noticed that people were more comfortable and slept better after a train or a carriage ride. Okay? And a lot of people over the years, a lot of my patients go to places where they go on a vibration platform. It vibrates them, and they say that it helps their Parkinson's symptoms. Charcot prescribed a daily 30-minute session on his vibratory chair for Parkinson's disease. And so I just want to say that there is something to this. Next slide, please. Vibration technologies for Parkinson's disease. Somebody else, this David Futrino, also has this gadget that he puts on the wrist, and it stimulates, and it's supposed to possibly help your Parkinson's disease. Now, there is a treatment for essential tremor called Calatrio. The Calatrio device, if you have essential tremor, you can wear the Calatrio on your wrist, and it actually sends electrical stimulation to your brain, and it helps your tremor, and it does work, okay? This is not like a crazy idea. This is real stuff that we're using for other diseases, called the Calatrio for essential tremor. Okay, next slide, please. So it's important, not just medicines and deep brain stimulator and hand vibration techniques, but we also really support art therapy, dance therapy, singing, physical therapy, occupational therapy, speech therapy. There's so many other things to do for Parkinson's disease. Next slide, please. So we had an art project during COVID, and Maggie Girard, she actually worked with patients online on Zoom, and they each were sent a little canvas, and each of them made a piece of the larger picture. And then we put this up on our wall in our clinic because look what a beautiful picture they created, and everybody contributed to it from home and worked on their piece of it. It's just a beautiful and symbolic of people expressing themselves and then creating something beautiful. Next slide, please. One of my patients, Ed, he always told me, I may have Parkinson's, but Parkinson's doesn't have me, okay? And so we got to keep going. We got to somehow keep on fighting this. Next slide, please. Rock City Boxing, we got Christy and Christine and all of our favorite people that are working hard to support each other with this disease. Next slide, please. And so I think Michael J. Fox and Muhammad Ali have done a great job for this disease. And I'll just end by saying, Michael says, acceptance doesn't mean resignation. It means understanding that something is what it is, and there's got to be a way through it. Next slide. That's it. Thank you so much. I'm just going to randomly take these. I just start with this one. CoQ10, is it helpful? No, it's not helpful, nor should you pay money for it. It might be helpful for some other problems like a heart transplant or heart muscle. But there's huge NIH-funded study that we did that showed that CoQ10 is not helpful for Parkinson's disease. And in fact, the people on the higher doses did worse than the people on the lower doses. So no, you don't need to spend any money on CoQ10. Okay, so in the slide that I showed about anticholinergics, acetylcholine is another neurotransmitter in the brain. There's dopamine, serotonin, acetylcholine. And one of the first treatments for Parkinson's was an anticholinergic medication. Adolf Hitler had Parkinson's disease, and his doctors gave him anticholinergic drugs. Okay. And so that's what they were using for him back in, 1941, 42. So anticholinergics are like Artane, which is trioxyphenadil, and Quercetin, which is benztropine. And so those were used in Parkinson's patients in the 50s, 60s, before levodopa came out. And so we still use them. And I think that there is a lot of misunderstanding about these drugs. We still use cogentin, benztropine. It helps tremor, rigidity, slowness. It is a great medication, especially for young people. Now, these are medications that have a lot of potential side effects, like they actually reduce acetylcholine in your brain, which can make you feel like you have Alzheimer's disease, because in Alzheimer's, you don't have an acetylcholine, so it causes short-term memory loss, constipation, dry eyes, bladder trouble. Sign me up for that, okay? So these are the anticholinergic medications, and they are really important in many people. And I have a lot of patients who are on them and they're helped by them. They're having side effects, but they just don't want to stop them because they really think it's helping their tremor, for example. So anticholinergics are commonly used in Parkinson's, but we tend not to use them in older people because of the cognitive hit that you can take from the anticholinergics. A lot of medications have anticholinergic side effects that you may have heard about, such as amitriptyline. Amitriptyline and nortriptyline are antidepressants, chronic pain medications, and they have anticholinergic side effects. Amantadine has anticholinergic component, and amantadine could cause a lot of these problems as well, but amantadine is such a good medication that we try to use it whenever we can. Okay, then I have a question here about protein. So actually, it's kind of a myth that we need a lot of protein. I think it's 0.8 grams per kilogram per day is what we're supposed to have. 0.8 grams per kilogram per day. You don't need very much protein. That's what the dietitians tell us. So you have to, if you have advanced Parkinson's disease and you're on levodopa, you have to understand the influence of the protein on your levodopa. This reminds me of, when turtles have babies, they make eggs, right? And they lay their eggs in the sand next to the ocean. And all the baby turtle has to do is crack the shell and make it into the water, and they're okay. But there are so many problems of them getting to the water because they have all these predators that try to prevent them from getting to the water. This is how I feel about levodopa. There are so many predators trying to make your medicine not work. So you really have to try to control all the variables as you possibly can. One of them is actually getting it into your stomach, swallowing it, okay? So a lot of people have to crush it up or chew it to get it down because they have a hard time swallowing it. But then it sits in the stomach for a long time and it's not absorbed there. It has to be propelled from your stomach into your small intestine, and it's absorbed in the small intestine. So this is the first problem, is that a lot of people with Parkinson's, as we've learned today, they have clumped up alpha-synuclein in the nerves around their stomach. So their nerves are not pumping their stomach properly, and they have what's called gastroparesis. And you may have noticed this, then you can't eat a lot of food at one time. You get early satiety. You can have just a little bit of food and then you can't eat much more because your stomach isn't pumping the food out because of your gastroparesis. And so what happens, especially first thing in the morning, is that the patients take their first dose and it sits in their stomach and it doesn't get propelled where it needs to go, and they have it delayed on to their first dose of the morning. And this is why they use the Apoquin shot sometimes to overcome that first thing in the morning. So you got to get it into the small intestine. Then in the small intestine, if there's any protein around, the protein competes with the levodopa. So if you've had steak and shake, okay, dairy and meat, okay, and it's in there, it's going to be absorbed into your bloodstream, and the cinema is going to be levodopa is going to be blocked from entering. Then, once the carb-levo gets into your blood, then it has to get into the brain. And there's all this enzyme in your blood that's breaking it down, preventing it from getting into the brain. So dietary protein is really important. Those dietary amino acids also block the entry into the brain. That's why if you are a fluctuator, if you have ups and downs and you have very bad off periods, you need to ask yourself, how much protein am I actually eating in a day? And then you need to say, I don't need 0.8 grams per kilogram per day or something. I need 0.7 or 0.6, okay? And so you need to have a low protein diet, and you need to just eat carbs and fat. You know, I would love to be told that I had to eat carbs and fat, okay? So that's just really a wonderful concept. And so then you have to divide it up into 25% at breakfast, 25% at lunch, and then 50% at dinner. And if you go to a wedding or something, then you might want to have fettuccine Alfredo or something instead of like a T-bone steak, okay, before you go to the wedding. So you know, you don't have to worry about this unless you have really advanced, you know, Parkinson's and you take levodopa and it doesn't work very well. Okay, so that's the protein situation. Can Embroxol be purchased through Amazon? I don't know. I've never tried to buy it. Does anybody know? Has anybody ever bought Embroxol? Does it have to be ordered from another country? Probably. FDA sometimes does intercept these types of things if they see them coming through. Sometimes there's medications that our patients order from other countries and they're intercepted by the post office. So I don't know how that's going to work. Has anybody tried to order Embroxol? Have you? I'm sorry. Oh, we're trying as we speak. Julie is trying right now. She'll let us know. You got to give us the follow-up. Can I get a copy of the presentation? Who asked that question? Presentation. Yeah, we're going to try to work on that. What is CUE1, QE1? What is that? I am on the QE1 waiting list. What is CUE1? QE1 is in
England right now, and it's another fibrotactile coordinated reset system where it's a button you push.
Oh, okay. So what vibrates?
It vibrates the button that you push, and it vibrates and it sends the messages to the brain.
Oh, it's some type of device that
Like
vibrates?
A coordinated reset, I guess.
I see. It's with that reset. I see. So somebody is working on getting on the CUE1 waiting list. Okay. No doctor's going to be able to prescribe that for you because it's not a proven treatment. So you're going to have to just obviously pay for that on your own. What does a movement disorder specialist role play on a care team? Well, it's really that we don't have that many Parkinson's doctors. And I think it's probably worthwhile to consider maybe going for a one-time consultation. This is what's going to be going on. There's going to be a deficiency of neurologists because nobody's going into this as much as they should, and there may be a deficiency of Parkinson's doctors. So I think that what's going to happen is that there's probably going to be a consultation where you have a general neurologist, and then you're going to go once a year or something to see your Parkinson's specialist because you're probably going to have to see a nurse practitioner or a PA, and we hope that they get, a lot of training so that they can provide care. But there's not enough people to provide care to all the people who need it. This is the problem right now, okay? And so we're going to have to, even right now you see the doctor, and then you see the PA, and then you see the doctor, so every other visit is with the doctor. And it's it's a long story, but it's not going to be any easier. It's only going to get more complicated, unfortunately. Are there any meds that help with dementia with Parkinson's? Yes, there are. First of all, you should try to stop any medicines that are making you have cloudy thinking. So like the amantadine can make you think unclearly. That's going to take a hit on your thinking. Anticholinergics, if you're on bladder pills to control your bladder, you need to stop those. Amitriptyline, nortriptyline, sedative medications like Valium, which last in your blood for a long time and sedate you. So the first step is to kind of clean the house and not take stuff that's making your thinking worse. And then you can go ahead and add donepezil or rivastigmine, which is in a patch form. So the Alzheimer's treatments work better for Parkinson's than they actually do for Alzheimer's disease, for dementia. So most of our patients later on, they are on the Exelon patch or the donepezil. These drugs increase acetylcholine. They help your thinking. And there is some chance that it may actually sometimes make your motor motor system a little worse because they're doing the opposite of what we'd like to do, but really it's worth it. I think if you are thinking about DBS, you have to ask yourself, how much is Parkinson's interfering with my daily life? If you are able to do the things that you want to do and go places that you want to go and keep to a schedule and make plans and feel comfortable most of the time, then you don't need a DBS, okay? This is for people who really have significant disability. The Parkinson's is really starting to block them from making plans, going on vacation, no planning whatsoever, because you just never know how your Parkinson's is going to be. If you have a lot of pain and your off periods are very severe. Some people have a lot of pain with Parkinson's. That when their medicine wears off, their muscles tighten up and they're very uncomfortable. This is my analogy. Think about a house with a basement and then a second floor. So you got a basement, a main floor, and then a top floor. And with people with Parkinson's who have advanced disease, the basement is the off time. When your medicine's not working, you are miserable. You can't move. You are stuck. You just horrible. You got tremor. You're just not functioning. You got a basement. Then you have a first floor, which is when the medicine's working, you're feeling pretty good. Then the second floor is the dyskinesia and you're wiggling. What DBS does is it takes most of the top floor away and a lot of the bottom floor away so that you're not as miserable as you were with the off time. And you're kind of living a little bit more often in the first floor. But it's not a cure and it doesn't stop all the problems, okay? If we know that sometimes it can make your mind not work as well. We're running current through your brain. People were trying to cut wires in your brain. And so if you have any susceptibility to having cognitive problems or if you have dementia, you shouldn't have this surgery because it's not going to make your thinking any better. In fact, we have had people who got worse with their mind and we don't know what the variables were that made that happen. But you have to get ready for that. I mean, some people look at the amount of atrophy on the brain. If there's a lot of atrophy and the neuropsych testing shows that the person is on their way to dementia, then they probably shouldn't have a deep brain stimulator. We now have really good testing for Alzheimer's disease. There is a spinal tap test for Alzheimer's disease. And so I think a lot of times people don't just have Parkinson's, but they also have Alzheimer's disease brewing. And it's hard to know how far to look for that. So half the people over 85 have Alzheimer's. And as we mentioned earlier, by the time you get memory trouble, you're in stage 3 disease of Alzheimer's. So it's been going on for a long time. So, this is a complicated business. How far do we go to see if you have concurrent Alzheimer's changes? How far do we go? Well, we try to pick that up on the neuropsych testing. So the DBS is not for everybody, but that's why you have to go talk to your doctor to see if it's for you as an individual. You all have the same diagnoses, but everybody in this room has a different type of disease. If you can learn from each other about certain commonalities, but really your cocktail and your cluster of problems is different from everybody in this room. Nobody has the same Parkinson's disease profile, and you all have your individualized problems and priorities. And that's why you really do need to be treated as an individual based on what is happening to you. Okay, pros and cons of DBS surgery and possible negative side effects. Well, yes.
Okay, y'all, I hate to interrupt Dr. Joanne because I know what she's saying is so much more important than what I have to say. However, we have 2 people who have bid on the twisted room escapes for the same exact amount. So the 2 people that bid on this, I need somebody to outbid the other one so that we can know who to give this to.
Now, which one is this for? Which basket?
The twisted room escapes. It's one of those escape rooms.
Oh.
And it's for a bunch of people. I know Lindsay's one of them. And
You can just go ahead and pick me.
or Kathy might want to fight you for it. I don't know. But anyway, I do need somebody to let me know if they want to, which one wants to pay more or whatever, because we've got to give it to somebody, and we want to give it to somebody. So, and I'm going to let Dr. Joanne talk some more, because
Okay.
Hey,
Well, so I don't even know what that is, what they're bidding on. That is. Okay. Yeah, I mean, you can be too old. You can be too old for DBS. If you're over 80, I think you're too old. If you have dementia, if you have a lot of problems with Parkinson's that are not motor problems, if you have anxiety, if you have depression, if you have dementia, these are things that are not made better with DBS. This DBS is for motor symptoms, okay? Why does it seem like a cold, an infection, or any other ailment seems like it's so much worse with Parkinson than before I get Parkinson's? Yes, we don't understand that. I mean, people can get COVID. You know, they seem to have a lot more trouble. You know, it takes Parkinson's patients a lot more time to recover from surgery. The spine surgeons know that the Parkinson's patient after surgery is going to need a little bit more time. I just think you have just a very complicated disease, and anything can knock you off your equilibrium. How about, could you explain the differences between idiopathic Parkinson's disease and then Parkinsonism? So somebody comes to the clinic and they have slowness, rigidity, and tremor. And do they have Parkinson's, or do they have multiple system atrophy? Do they have progressive supranuclear palsy? Have they been on some medications that are causing that? So idiopathic Parkinson's is a very classic thing where it's slowly progressive, starts on one side of the body. Usually about 85% of people will have a resting tremor on that side of the hand or the leg. It doesn't go over to the other side right away. It takes a while for it to cross over. And they respond to medications, and they don't have balance problems early. They don't have dementia early. So we know when we hear the story about whether this is a classic Parkinson's or not. And so a lot of people who have multiple system atrophy, they present with, they start passing out. They have autonomic trouble. Their blood pressure drops. They have bowel and bladder trouble, constipation, bladder doesn't work. They don't respond to Parkinson's medications very well. They have other problems, and their MRI can be abnormal. So multiple system atrophy is often mistaken for Parkinson's disease early on. And those people don't respond to DBS. So you really have to be sure somebody has Parkinson's before you recommend a DBS. Oh, sleep trouble. Well, you know, sleep is very complicated. I think about a symphony that requires, I don't know how many instruments are in there, but let's say 100 instruments. You need to have all the instruments playing at the same time in good order in order to have the music sound good. Because if a couple people aren't playing well, then the whole thing is not working. Same thing with sleep. Sleep is very complicated. It requires a lot of chemicals, and a lot of these centers in your brain that have these neurotransmitters, they are sick. They're not producing serotonin, norepinephrine, dopamine. And so the whole orchestration is not going to work, and that's why so many of our patients have disrupted sleep. And we have, and yet one of the most important things, the top two things I think in Parkinson's to have a good day is to have a good night's sleep and to have good bowel movement in the morning, okay? You can't be constipated, because if you're constipated, then the medicine, why would the stomach pump more levodopa and stuff into the intestine when things are backed up? Like, there's a communication between the colon and the stomach, and so you need to really keep your colon clean. You also need to sleep at night. We would be happy to help you, find ways to sleep better. Sometimes you need to take pills to sleep better. But there's sleep hygiene, right? You shouldn't be watching an Arnold Schwarzenegger movie before you go to bed. You should be on the computer doing war games or something before you go to bed. You need to take, a warm bath. Your bedroom needs to be cool. It needs to be dark in there. You can't have 10 cats on the bed with you and a couple of pit bulls, because they're going to keep you up at night. What's the pet situation? And so all these things matter for sleep. And then, your body temperature, you can't be too hot. You got to be cool before you go to sleep. Some people take the Tylenol PM, and it lowers your body temperature because of the Tylenol in there. So sleep is a complicated thing. You may have sleep apnea, and you need to get a sleep study. If you're not sleeping well and you're not rested, you need to have a sleep study. Sleep apnea is so easily treated. Okay. I don't think that COVID was any worse for Parkinson's patients in any particular way, but we are finding that there's a lot of movement disorders that have occurred as a result of COVID. I do think Parkinson's is becoming more common because of all the junk around us. Is there any limitations to lifestyle after DBS? Well, not really, except for the electrical. You have to be very careful that nobody puts a current through your body, because if you're exposed to an electrical current, it may get into the wires and it may sizzle into the brain area. So you have to be very careful not to fry that area. It's just really in the dentist, like some people go to the dentist and they use cautery or some type of electrical stimulation. You have to be very careful in the dentist's office. Exercise, okay. I think when you exercise, you produce nerve growth factors in your brain. It really does produce fertilizer for neurons, and I do think you should exercise as much as you can. So clean colon, good night's sleep, exercise like a maniac. If you have Parkinson's, you really have to do that. And then also don't drink too much alcohol. I'm going to say something about alcohol here. Even though I'm probably going to get a lemon drop martini tonight somewhere in town. I don't know where. But I do like the lemon drop sometimes. But you shouldn't really be drinking too much, okay? Because alcohol is not good for Parkinson's. And you have found this out. You know that if you have too much wine or something, that it causes, you're dehydrated, it makes your balance worse, it disrupts your sleep architecture. I mean, and we used to think that, red wine is good, it's going to make us live longer and prevent heart attacks. But now they're finding that there is no benefit. There's no health benefit probably of alcohol. In fact, it's only bad for us. It doesn't mean we have to stop drinking, but we just have to think about it as a factor in our lives. And one of the things that I didn't realize is that alcohol blocks DNA repair, which is why a lot of people who smoke and drink, they get the head and neck cancers, cancers, they get the throat and all that stuff. It's not so much smoking, but it's the smoking and the drinking. And they go together, those two, right? Okay. So that the smoking and the drinking together do that. So I think you just got to be careful. Not that we have a whole bunch of people drinking in here or doing cocaine or anything like that. I don't see a lot of cocaine addicts in the room here with us at the MCL. But I do think we have to think about the alcohol. So those are the tips for healthy living with Parkinson's. And then that's all I have really for the questions.